This is HealthCall Live online, where we feature extended versions of the interviews that we air on our radio broadcast each week. Glad to have you here. I'm health correspondent Lee Kelso. Cardiovascular disease remains the number one killer in the United States, and that is also the case down under, where Dr. Warrick Bishop is a practicing cardiologist, author, and broadcaster. He's the author of Know Your Real Risk of Heart Attack and Have You Planned Your Heart Attack? He also has a new book about Afib, atrial fibrillation, we'll be discussing today as well. So Dr. Bishop joins us from his office in Tasmania, where I understand your weather is lovely. Thank you for joining us, Doctor.
Yes, it's a beautiful morning here today, Lee, and pleasure to be up and pleasure to be joining you for this interview. Thank you.
I appreciate you making the time. So I love your title, Have You Planned Your Heart Attack? It hooked me. What does that title mean?
Lee, over the years, I've had, as a cardiologist, 20 years experience of meeting people who literally, when they have their heart attack, ask, why me? I didn't see this coming. I didn't understand it. I even had a psychic patient once who was beating himself up because he didn't even predict it coming as part of his own skill set. And the reality is people don't have a chance to recognize what's ahead. And the book was written about latest technology, which can allow us to actually be proactive so you can plan not to have your heart attack.
Oh, well, let's dig into that. What technology are you referencing and how do I access it? What is it going to teach me?
Look, as you're probably aware, cardiac CT imaging over the last 20 odd years has evolved so that the technology allows us to take pictures of the beating heart which are reproducible and reliable. And those images, whether they're calcium scoring or whether they're injection of contrast to give us a CT coronary angiogram, literally give us pictures of the health of someone's arteries and therefore far more precision around trying to calculate that person's risk into the future.
Yeah, I'm glad you mentioned arteries there because we think of the heart, but really the problem in many cases is coronary arteries, correct?
Absolutely, Lee. And often the analogy I use with patients and the analogy I use in my book is if we think of the heart like a car engine, then the ECG, which we do with dots on the chest, tells us a bit about the electrical system of that car. The pumping chamber of the heart is the compression chamber or the pistons and valves of the heart, but it's the fuel lines, which are the arteries supplying that blood, which is essential for life. And any of those components can play up, but it's often the fuel lines, it's often the arteries.
So, is that the cause of otherwise healthy people falling over dead? Have their fuel lines just become clogged shut?
Well, look, this is a question that's incredibly important, and it explains the situation that we come across regularly where someone who appears fit and well drops dead and we all scratch our heads going, well, they look like they cared for themselves, they didn't smoke, they've just come out of the gym. And when we look more deeply and we look at the pathology of what occurs, the actual processes within the arteries, what we find is that the buildup of plaque or cholesterol doesn't have to be narrowed up until the point that that plaque ruptures. And when that plaque ruptures, a clot forms on the plaque and blocks the artery. So right up until the moment of instability of that buildup of cholesterol in the artery, the person can be without any symptoms at all, completely unaware.
So obviously that's why it catches us all by surprise. And the technology you mentioned, the ability to image those arteries is the key. So you are being able to see how much fuel, how much blood is getting through that artery?
Well, at the very best, Lee, we can start off by getting a sense of the health of someone's arteries. And calcium scoring, for example, is a test that's now started to make its mark in guidelines, both in the United States and in Europe. And the use of that sort of imaging gives us an idea of the heart arteries healthy, i.e. no calcium. Are they really unhealthy, lots of calcium, or somewhere in between? And although that's not incredibly precise about narrowing, it's a great starting point to start to sub-stratify the risk of a group of a large population.
So calcium testing in this country is relatively expensive and widely available. When should I start that process? Who is the candidate who should have that test, and how often should I have it repeated?
Yeah, look, they're great questions. I do touch on those a bit in the book, and I'm pleased to say that since writing the book, 2 guidelines have come out, American and European, and they're really pointing towards this test being a great risk stratifier for the intermediate risk population. Now, an intermediate risk population is defined medically as a group of people who will have a risk of somewhere between 10 to 15% of a heart attack in 10 years. But to put that into practical terms, it's an average 50-year-old bloke or an average 60-year-old woman. And so it's a really good time at 50 odd years of age for a male or 60 years of age for a female to start asking questions, should I be having my arteries checked, just to be more precise? And my own feeling is if there are other risk enhancers, other things that may increase our concern for an individual, like particularly high cholesterol or a particularly bad family history, you bring those ages down by 5 to 10 years.
And then how often should I have that test repeated, assuming that I have, an average risk, the average bloke, as you put it?
Look, in general terms, we think if we define calcium in someone or define calcium and recognize that represents plaque in the arteries and the extent that it's in the arteries, we would start treatment. Once we've started treatment, we don't normally look to repeat the imaging. So the imaging is valuable for people who have no calcium in their arteries on the first scan, because what you want to do is make sure you're not missing the development of plaque in the arteries. So a 5-year span after a 0 calcium score is what's generally recommended.
Okay, so that's kind of on par with a colonoscopy procedure in our country then. So
Yeah.
Periodically, I got it. So,
Yeah.
so then treatment often involves statins. There is some controversy around statins and whether they're as effective as they might have thought to have been. Some people were recommending at one time that they should just be put in the water. We should all be taking a statin. What's your thinking now that we've seen more years of research?
When we look at people with high cholesterols and try and figure out if they're going to have a heart attack, well, some do and some don't. When we look at people with low cholesterols and try and figure out if they're going to have heart attacks, well, remarkably, many people with average cholesterols have heart attacks and some don't. And so if we were to take cholesterol, high or low, as our predictor of who's going to have a heart attack, it's not particularly reliable. And so if we were then to say, let's treat people with statins, with high cholesterol, we're not going to be very successful in our endeavors. So certainly a lot of the controversy around the statins, the so-called controversy around statins, has been giving it to people before they've had an event based on their cholesterol level. And just common sense dictates from our experience and observation that that's not a great way to do it. But let me flip it around. Let me turn it around and look at people who have had events. Now, there is overwhelming data over the last 20 odd years that if we take people who are truly at high risk, who have manifested themselves by having had an event, then if we lower their cholesterol levels, regardless of whether their cholesterol level is high or low or in between, if we lower their cholesterol level, we will improve their outcome. And so the answer to the question is, if you have clear-cut high-risk plaque in your arteries, then lowering cholesterol will make a difference, and the statins work at that. Everyone will have some sort of different tolerability to medications. That's just the way of the world. But many, many people tolerate these medications without problems at all and have an event-free, cardiac event-free life, which is extended substantially by the medication.
And to your mind, then, the coronary artery scan is the gold standard to indicate who is at high risk?
I don't think we have a perfect test, but it's a very good extra discriminator in terms of giving us extra information. We often start with traditional risk factors, as you're aware: age, sex, blood pressure, cholesterol levels, blood smoking status, diabetic status. We use those as traditional risk factors. They help us define populations. If we overlay imaging the heart to that, we get extra information. We can be more precise and know who to target with a greater intensity and who to target with a less intensity.
So, in your experience, is blood pressure a risk factor for coronary artery disease, or more so for stroke? And which do you pay more attention to, that cholesterol level or BP, or is it both?
Yeah, both, of course. You wouldn't take your car for a service and ask them to just check the brakes but not check the oil. It makes no sense at all. Our endeavor is to make sure we give people a healthy journey through their life. So I often use a car analogy because I think it's a great way to visualize it. We would want to do everything to make sure our vehicle is reliable and safe and has the longest life possible. We should be doing that with our own bodies. When it comes to blood pressure, it's often poorly managed, it's poorly treated, and it's a huge consequence. Lee, this is one of the single biggest things we could do to make a huge difference across the board in a population. It's associated closely with stroke. It's associated closely with heart attack. It's associated closely with cardiac failure, and it's associated closely with atrial fibrillation. So yeah, blood pressure is a really big deal.
Yes, it is. And it's interesting that we're seeing the recommendation now trend down. In our country, they're saying 130 over 80 is the upper limit. Is that still the thinking?
Look, my own practice, and I think that literature is suggesting this, what we see is that the blood pressure is the wear and tear on the vascular system, on the pipes, and the pump, the heart. And so if we can lower the wear and tear on the pipes and the pump, we can improve the longevity of that system. And so the answer, I think, Lee, is we bring blood pressure down as low as possible with my own patients. I try and bring their blood pressure down, but make sure we don't cause side effects. The biggest issue is if you lower blood pressure too much, people stand up, feel lightheaded, and you can't live that way. So I actually work with my patients to bring it down, make sure I don't make them too hypotensive, too low in their blood pressure, and we run as low as we possibly can. Obviously, actually, lifestyle and weight are really important as part of that equation, because as you're probably aware, and some of your listeners would be aware, as you drop weight, you reduce your blood pressure. In our terms, 1 kilogram, which is probably 3 pounds, I guess.
Yes, about 2.2, I think.
Yeah, one kilogram weight loss is 1 millimeter of mercury reduction of blood pressure. So 5 to 10 kilograms of weight loss is 1 blood pressure tablet drop. So we deal with the whole car. We try and lose weight, keep the blood pressure down, and keep the engine and the pipes running well.
Well, where I live, the metabolic syndrome and diabetes are just epidemic. Is it that way in your country as well?
There are in parts. Certainly, there's been a propensity towards that over the last several decades, and that's been the case right around the world, as you're aware. And as you're probably aware, I think a lot of that is related to more and more carbohydrate and particularly sugar ending up in the diets of adults, but most importantly children, because I think we're seeing more and more young adults and teenagers and children putting on weight, and they don't drop it through their lifetime, which is very distressing, actually.
Yeah, I agree with that. A lifetime of inflammation just has a toll on your entire body there, doesn't it? Atrial fibrillation is your latest book, and it is an extremely common condition. So correct me, please. You are the expert, but Afib refers to the upper chambers of your heart sort of vibrating and not effectively pumping, correct?
That's a great assessment. That's exactly how I'd describe it.
And so that increases the risk of clots and other issues occurring. So what can you teach us about Afib?
Well, I think like most conditions, prevention is better than cure. And for atrial fibrillation, things like blood pressure are a very important driver. And that's able to be changed and modified. The single biggest driver for atrial fibrillation, in fact, though, Lee, is age. And what we see is a incidence of atrial fibrillation across a Western population at about 1%. But when we look at individuals over 80 years of age, that incidence is about 15%. So we can't modify our age, but it's good to be aware of it, and it's good to start getting regular checks. And the recommendations in the Australian guidelines, and I think this is reflected in the American guidelines, is that regular opportunistic checking of the pulse for individuals over 65 years of age is a really good thing to do, because we know that there's a good number of people walking around with atrial fibrillation and don't realize it. And much better for that to be detected by someone feeling their wrist or checking an ECG than that person turning up with a stroke and then being found to be in the rhythm. So being aware, trying to look after yourself, good sleep is good. Not being overweight reduces your risk. Too much alcohol will increase your chance of atrial fibrillation as well. It's a really interesting condition.
Yeah, so all of us who are wearing biologic monitors, our smartphones and watches and that kind of thing have better access to that information than ever before. But if all I can do is check my pulse and feel my wrist, what am I feeling for? What should I be looking for?
Yeah, okay. So the term we use in medicine is irregularly irregular. Irregularly irregular. So try and imagine someone dancing who's intoxicated at a uni bar and they're completely out of tune with the music. They're missing thumping, bumping, big swings, small swings, irregularly irregular. So the heart loses that beautiful synchronicity. And there are two things that happen with that synchronicity, obviously. One is that the pump doesn't work as well. So we do see symptoms from atrial fibrillation. We see consequences. Those consequences are stroke, but the symptoms we see are people drop about 10 to 15% of their cardiac output. So people who exercise, for example, particularly with these Fitbit and monitor devices, can be very clear about when their atrial fibrillation kicks in, because their performance level just drops by about 15%. And that's because the pump's not working as well, loses its timing, and the pre-pumping doesn't work.
Very good. I want to hit you with just some lightning round questions, if you please. So short questions, fast answers. Aspirin therapy has been very popular, also controversial. Are you a believer, yes or no?
So look, it's a great question. I get the question regularly, and it's been confused in the media. And so I'd rather take a moment to make sure people don't get that confused, because it can cause problems. Recently, there have been 3 major trials come out, probably in about the last 18 months, looking at literally, should we put aspirin in the water? Each of those trials, with large numbers of people, took individuals at intermediate risk to see if giving aspirin was beneficial. And it turned out that by giving aspirin to otherwise relatively healthy people, the benefit in reduction of heart attack was offset by the increase in bleeding. If we look back at history, though, the very first trial which gave us good information about aspirin was the ISIS-2 trial. And in the ISIS-2 trial, what we did was we looked at people who defined themselves as high-risk individuals, people who had had a heart attack. And there was absolute clarity, and there has been absolute clarity since in multiple trials looking at aspirin, that if we find those very high-risk people have defined themselves with a heart attack or an event, then aspirin is beneficial for them. Now, if we stop and think about it, what that actually means is if we can find someone just before they're going to have a heart attack and give them aspirin, it will be beneficial. And if we work back from that, instead of giving aspirin to an intermediate risk population, what if we scanned that intermediate risk population, found the people with really high calcium scores and gave them aspirin, such that aspirin was on board just before they had their heart attack? But no one's done that trial. So the answer to your question is aspirin shouldn't be in the water. There's no question about that, no doubt. Aspirin should be given to everyone who's had a stroke or a heart attack. No question about that. In my practice, I believe there's a role for aspirin in individuals who we image and find high-risk features, recognizing that they're at very high risk of developing an event. And so I use it in my high-risk patients in a preventative setting. There's no question it should be used broadly in a secondary prevention setting.
So much like your approach to statins then, once there's an indication, jump on board, but until then, maybe not.
Lee, that's exactly right. And I think this is, in fact, the way we should apply the use of most of our medications. I think we should, for each individual, be figuring out the risk and benefit of the medication for that person. And so if we've got a high-risk individual, then medication makes sense. If we take low-risk people and give them cholesterol lowering or aspirin, we'll be treating many people who won't get any benefit from it. And so I think precision becomes a really valuable adjunct to best care in this situation.
So let's talk a little bit about the difference. I mean, it's wonderful that I have an opportunity to talk to someone who is outside the U.S. healthcare system. Tell me about your approach and how it differs from what we in the United States understand. I assume you're well up on what we do here and how broken our system is, so many people believe. How is yours different? Are you a public health system?
Look, we've got, I work as a private cardiologist. To be honest, I don't have a clear handle on the intricacies of the US system, so I'm not in a great position to comment on that. But in Australia, we have a safety net system which covers everyone, and that's called Medicare. And so for every consultation, every procedure, everything that can be done in medicine, there's a safety net, and that picks everyone up, and that is paid for through our taxation system and represents a portion of the gross domestic product. We also support our pharmaceuticals that way. Now, we also have the opportunity for people to see patients, our patients to see private doctors, and that's what I am. It means that everyone really gets good care.
What can we learn from your health habits? What do you do that I need to adopt to keep from having an incident, having an event, and becoming one of your patients?
Well, look, I think one of the most important things is to be educated. And I think we've come in contact with each other because you've found a lot of the educational resources that I've tried to produce. I think once you have a better understanding, a better health literacy, you have a better idea of where you should be going. So personally, I've been scanned. Personally, I check my bloods and make sure that they're all in order. And they're very simple medical things, but on a day-to-day basis, I make sure I keep a healthy weight. I exercise regularly. I start the day with a few nuts. I eat plenty of greens. I don't eat much carbohydrate. I enjoy plenty of olive oil. I have 1 or 2 glasses of wine most days. And I see my family and friends and try and relax when I can. So it's a bit of a mix of keeping your head clear and looking after your heart and your other health as well. But I think it's really important for people to be aware of the opportunities to be proactive and preventative, because you can do all the so-called right stuff. And you know this, and your listeners will know this. There are plenty of stories of people who look fit and well, walk out of the gymnasium and drop dead. So you have to combine a bit of science with a bit of common sense.
Yes, excellent advice. One last question. Is there anything I didn't ask you that you think people need to know and we should have touched on?
Look, I think that's a great starting point. I'm really glad we got to spoke about aspirin and cholesterol and blood pressure. These are huge topics, and there's simple things to do. I think imaging is a big thing, and I think we're going to see more and more imaging. And I'm really looking forward to the opportunity where we can literally prevent people having heart attacks by finding unhealthy arteries way before they cause a problem and putting in appropriate interventions, because our medications work. So I'm looking forward to a healthier future for everyone.
Well, thank you very much. Dr. Warrick Bishop is a cardiologist in Tasmania. You can find him online at drwarrickbishop.com. I encourage you to go there, and you will learn a great deal about one of the most important heart organs in your body, your heart and your cardiovascular system. My thanks to you, Doctor.
Thank you, Lee. Appreciate it.